Anna, you're on mute.
Thank you so much. I didn't realize. Okay, so we'll get started. Today marks the launch of conversations around anti-racism within critical midwifery studies. And I'm your host, Anna Horn. I'm a doula and a PhD candidate at the Center for Maternal and Child Health Research at City University of London. The Center for Maternal and Child Health Research at City is partnering with the Humanizing Birth Summer School to bring forward this webinar, Critical Midwifery Studies, Anti-Racist Perspectives. Shall we move to the next slide, please? So we planned today to hear from leaders in anti-racist maternal health research, care, and activism in both the US and the UK. And yes, that also includes you, our webinars, and summer school participants. Today's speakers range from academics in anthropology, maternal health researchers, and practicing midwives, all contributing to multifactorial strategies needed to provide culturally safe, personalized care to racialized women and birthing people. Before we dive into the wonderful work of our speakers today, I'd like to take a moment to set the scene and describe a brief overview of the landscape of birth for racialized women and birthing people in the US and the UK. So, as I mentioned, the context for today's speakers are the US and the UK, which are two high-income, diverse, multicultural countries with histories of colonialism, imperialism, and links to slavery. Income inequalities among both US and UK populations are wide, and both qualitative and quantitative research point to the inequalities in resources such as income, education, access to healthcare, and more as major contributors to health inequalities. One particular exposure, and perhaps controversial, which also results in poor maternal health, well-being, and experiences is racism. And that's what we're going to be talking about today and putting forth anti-racist perspectives. So just as Angela Davis said, in a racist society, it's not enough to be non-racist. We must be anti-racist. And that is definitely the sentiment that is a thread throughout our work today. So to borrow the term racist environments from one of today's speakers, medical anthropologist, Dr. Natalie Valdez, she describes this idea of racist environments as exposure to racism as discursive, experiential, material, and visceral. And I wanted to allow me, please, a brief outline of some of those aspects of this racist environments in which people live, most recent developments, and its impact on health and well-being as it relates to maternal, reproductive, and infant health care, support, research, and advocacy. So that's what I hope to outline for you today. So the most recent headline for coming out of the US has been the overturning of landmark Supreme Court case Roe versus Wade. And this court case made abortion legal across all 50 states. However, on June 24th of this year, the US Supreme Court ruled in Dobbs versus Jackson Women's Health Organization that the right to an abortion is not upheld by the Constitution and thus rendered the decision to either legalize or outlaw abortion back into the hands of individual states. So prior to this ruling, reproductive justice advocates, abortion care practitioners, midwives, doctors, doulas, and community organizers gave warning to the systemic deconstruction of abortion rights, imposed restrictions, and in other words, the chipping away of reproductive health care, which ultimately impacts the most marginalized and historically disadvantaged groups of society, including poor women, racialized women, and we're talking about Black, Indigenous, Latina women, young women, women facing vulnerable circumstances and social complexities. I also want to recognize that it also impacts trans, queer, and gender expansive people in ways that many have yet to even consider or accept. And of course, all of these compounding impacts intersects with identity of disenfranchised communities. The US adopts a healthcare system based on private insurance and direct fee payments, which leave many people vulnerable to inaccessible healthcare. Among high-income countries, the US pays more in healthcare and yet has some of the worst healthcare outcomes, including maternal mortality. According to the Center of Disease Control in the US, Black women are nearly 3 times more likely to die due to pregnancy-related causes compared to white women. We also know that when compared to white women, Indigenous women experience severe maternal morbidity and mortality. Elevated incidence of avoidable maternal mortality and morbidity is a grave reality that disproportionately impacts racialized women and birthing people in the US. And it's only the tip of the iceberg. Many Black, Indigenous, Latina, and other racialized women and birthing people are born, live, grow, and ultimately become pregnant in racist environments, which sometimes includes healthcare that they receive. One of our speakers today, anthropologist and ethnographer, Dr. Dana Ann Davis, coined the term obstetric racism, which Davis describes as the intersection between medical racism and obstetric violence. Many in the academy, in healthcare, and in the community have worked tirelessly against reproductive injustice in America for decades, many of whom are Black women and women of color, working on the front lines of reproductive justice activism, anti-racist healthcare, and inclusive and culturally safe solutions. And solutions are what we're going to talk about today. And so one solution put forward to improve maternal health and well-being and the racial inequalities is to make midwifery and doula care more accessible, as research demonstrates improved healthcare outcomes and experiences when women and birthing people have access to midwives and doulas. However, in a webinar that's focused on critical midwifery studies, it must be noted that midwifery in the US is marginalized in many ways, if it's via education routes or which states you can practice, and the historical exclusion of Black midwives. Other solutions to address racial disparities in the US include grassroots efforts with some support from institutions to make doulas more accessible to families, particularly for underserved communities, to increase midwifery accessibility, and particularly to recruit Black midwives, to create midwifery-led settings where midwives autonomously practice the art of facilitating physiological birth, including works of Jenny Joseph, who's one of our speakers today. Another solution is the implementation of Black centering, which is a racial congruent model of centering pregnancy, where Black midwives facilitate group care among pregnant Black women and birthing people. Now let's move over across the Atlantic over to the UK. So the UK is made of 4 countries: England, Scotland, Wales, and Northern Ireland, all of which provide publicly funded healthcare to their residents. Maternal mortality in the UK is lower compared to the US, but the pattern of racial inequalities is similar for marginalized and historically disadvantaged communities. The most recent Mother and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK report, most commonly referred to as Embrace, found that compared to white women, Black women are 4 times more likely to die of pregnancy-related complications. Women of mixed ethnicity are 2 times more likely, and for Asian women, nearly twice as likely to die in pregnancy or around the time of birth. Unlike the US, midwifery in the UK is widespread across the country. Most women and birthing people receive care from a midwife. Some critics argue that perhaps midwifery is institutionalized. And I very, very cautiously say that in some cases, this renders it to be a disservice to women and birthing people, when the philosophy and art of midwifery is restricted due to the interest of a biomedical model of healthcare. Like in many parts of Europe, the marginalization of midwifery has historical roots, issues which in many ways oppress a woman-dominated profession which serves women and birthing people. So just last year in 2021, March with Midwives UK, which is a campaign and made of grassroots organizers, called for the government to improve the working conditions for midwives in the UK, particularly after a survey from the Royal College of Midwives warned of a midwife exodus due to understaffing and fear of delivering unsafe care. Many midwives, birth advocates, and service users accentuated how understaffed units, burnt out staff, and low retention within the profession also contribute to poor maternal and infant outcomes and experiences. Many maternal health practitioners, advocates, and activists in the UK highlight that racial inequalities have existed for decades, and equally, so have the efforts to address them. The struggle for reproductive freedom and equitable maternal health and well-being, like in many places, is overcome by seen and unseen efforts, big and small moves, steps, and gestures toward a society which centers accessible, culturally safe, and personalized care, and addresses the wider influences which negatively shape our health. The past few years have ushered in a wave of initiatives to address inequalities in maternal health, and also some missteps. In the past 12 months, 3 reports were released which provides essential surveys and qualitative research about the experiences of women and birthing people from Black, Asian, and mixed heritages. So they are the Induction of Labor Survey and Webinar by the Women's Health and Maternal Wellbeing Initiative. 2, Systemic Racism, Not Broken Bodies by Birthrights. And 3, the Black Women's Maternity Experiences Report by 5 Times More. Other triumphs include the revision of the 2021 National Institute for Health and Care Excellence, NICE, draft guidelines for induction of labor, which included policy that guided clinicians to offer induction of labor to women at 39 weeks to people who are to have a Black, Asian, and minority ethnic background, among other women and birthing people deemed high risk. As a response to the 2021 draft guideline on induction of labor, received responses from a wave of doulas and birth advocates, activists, researchers, midwives, obstetricians, and maternity care workers, which oppose a systematically racist healthcare guideline. And this motivated the change. I want to point out that the UK's strong point is that healthcare is free at the point of entry, and many service users have access to midwifery care, including the benefits of midwifery-led care. However, providing universal coverage in this context has sometimes, it has unintended consequences, including an industrialized model of healthcare. Those who spoke out during the March for Midwives campaign highlighted how an industrialized approach to maternity care impacts both midwives and service users. Another win is that the Center for Maternal and Child Health Research at City University of London, in collaboration with the Midwifery Unit Network, led by one of today's speakers, midwife and researcher, Dr. Lucia Roca and Nacho, developed midwifery unit standards, which include themes of equality, diversity, and social inclusion. Many of the small and often unseen efforts to address UK racial inequalities in maternal and infant health are also at the heart of everyday practitioners, doulas, advocates, and service users. The Albany midwifery practice and Mimosa midwives are often noted for their exemplary models of personalized and culturally safe midwifery-led care, among many others around the country. The call for increasing ethnic minority researchers, particularly those from Black heritages, research which highlights the nuance of individual ethnic groups, and midwifery-led research are also put forward as some of the multi-pronged solutions in addressing racial and ethnic disparities in maternal health and well-being. Today's speaker, Natalie Valdez, dives deeper into how we think about research, the ways in which it impacts how we understand the problems, where we place efforts of intervention, and ultimately, how we address racist environments and the wider social determinants of health. Adverse maternal and infant health and well-being outcomes and experiences where Black, Indigenous, and racialized people are disproportionately impacted. And it's a transnational crisis that occurs across different types of healthcare systems. Anti-racist work in maternal health is a long-haul journey. And at times, as a doula and a scholar activist, I even feel weary. I feel frustrated and burned out. However, like all of you here, I believe in maternal and reproductive healthcare that centers the needs of women and birthing people. I too believe that racism in all of its forms need to be eradicated and that people deserve, as Sister Song Women of Color Reproductive Justice Collective put it, the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. Today, I'm honored to host a wonderful webinar with speakers focused on anti-racism in maternal health outcomes, well-being, care, support, and research. Today, we'll hear from Dr. Dana N. Davis, Dr. Natalie Valdez, Jenny Joseph, Dr. Lucia Roca Enacho, and Dr. Cassandra Yule. Together with you, the participants, we will dive into deep conversations, reflections, and participate in a workshop to explore anti-racism in maternity care and how this work shapes the aims of critical midwifery studies. So grab your pens, your paper, and some snacks. Set yourselves up in your living rooms, your kitchens, and on your sofas. Interact with us on the chat, on It's Learning, and on the app Discord. Tweet using the hashtag SMS 2020. So thank you so much for being here with us today. We appreciate all who are joining the webinar, and for those who are joining for the week, school is now in session. Again. I'm on mute again. You might have to remind me today. Anna, you're on mute. So we've got a few more minutes before our first speaker joins us. Oh, she's already here. Hi, Dana.